The video series Glycemic Control Oral Agents was developed by the Georgia and Oklahoma Academies of Family Physicians as part of the Go Diabetes Initiative. The Glycemic Control Oral Agent series consists of 6 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for your participation in this online activity and hope that it serves as a valuable educational tool.
Okay, TZDs have been in the news a lot, and so we're going to talk a little bit about that as well. The long name, which I'll say one time, thiazolidinedione. I worked all day yesterday on that. It'll be forever else be known as TZDs. There's 2 on the market right now. There's been 3. There was one that was pulled from the market named Regulin several years ago. But the 2 are pioglitazone or Actos and rosiglitazone. By the way, sometimes I'll use the trade name and sometimes the generic name. I'm not trying to favor one over the other. But Actos and Avandia are the 2 TZDs on the market right now. Their mechanism of action is they increase insulin sensitivity. So they also slow down the production of glucose by the liver. And there's some people that think that they decrease the rate of beta cell dysfunction. They slow down the decrease in insulin production that you get from beta cells. How effective are they? Well, they lower the A1C somewhere between 1 and 2 percentage points. My personal experience is that Actos probably lowers it closer to 1%, whereas Avandia was a little more potent at lowering A1Cs. But somewhere in that percentage rate. So when you compare that to like a sulfonylurea, which is definitely in the 1 to 2 percentage rate or range, or metformin, which is there, that gives you a little bit of a comparison. Main side effects that are commonly seen include swelling or edema, weight gain, anemia. I don't think I've ever seen that. Rare risk of liver failure, and that's basically a historical risk from Regulin. You might, and that's why it is recommended you monitor liver enzymes in patients that take these. And the recommendation to monitor liver enzymes, it's not like every time they come in they need the liver enzymes every 2 to 3 months checked. I usually check them once, maybe twice a year. If I have a patient on them, it's very, very infrequent that you see anything like that. The maximum dose, or the effective dose rather, is usually at similar to sulfonylureas, where you're going to hit about half the max dose, and then at that point I wouldn't recommend. You're not going to get much more blood sugar lowering by increasing the dose up to the maximum dose, if that makes sense. We're going to talk more about these. I remember when I was a faculty in Oklahoma City, I had a patient, resident was presenting a patient to me, it was one of these types of people who has obstructive sleep apnea, weighs 300 pounds, is on a grocery bag full of medicines, and patient came in, or the resident said, they've gained 40 pounds in, it was like a month. And I'm like 40 pounds in a month. I mean, how do you? It's what you can't tell by examining the patient if they gained that much. I mean, they always have swollen legs. You look at them, you can't tell anything. Good luck looking for JVD or something else. When you look at their neck, but you put them on the scales and you can say that's 40 pounds. It's 40 pounds on the scale. It was a patient who happened to be on a TZD and had been initiated within 1 or 2 months previously. Was on insulin. Also, of course, had obstructive sleep apnea. Had other reasons that they could have right heart failure and things like that too. But just to remember, if you do see somebody that decompensates and all of a sudden comes in, it's like, man, you put on 15 pounds in a month. If they're on a TZD, really think about that. The weight gain associated with TZDs is a result of both fluid and fat. So there's two things that cause it. It appears to be proportional to the level of glycemic control. It's not inevitable. If they do watch their diet, then it's helpful. It is worse if they're on sulfonylureas or insulin. Those things are kind of like fuel to the fire in people who are treated with TZDs. Yes?
Is there a contraindication then in using these with patients with CHF? And would you tend to see this edema or weight gain right after they start it, or can it happen even if they've been taking it for 5 years?
Next slide, I think, will answer that question. So, if it doesn't, let me know. But so patients should be instructed to inform their doctors if they do gain weight rapidly. Actually, it's a slide after this. Interestingly, they affect lipids in some unique ways. Okay, and this was a randomized. Oh, sorry, this wasn't the randomized controlled trial. The next slide is that. But basically, both agents, both Actos and Avandia, raise LDL. They both raise HDL. Actos seems to lower triglycerides, whereas Avandia tends to raise triglycerides or be more neutral with triglycerides. They do have black box warnings for CHF, basically meaning that you need to be keenly aware of that if you're prescribing these. Rosiglitazone or Avandia has one for heart disease. And so that was a big thing that came out about 2 years ago, that it seemed to be a slightly increased risk of ischemic heart disease in people who took Avandia. Actos has the warning for CHF, but not the warning for ischemic heart disease. Interestingly, they also seem to have somewhat of an association, a weak association, not a huge one, but with osteoporosis too. It seems to happen a little bit more frequently in people treated with those. So, they have some unique benefits, but, here's just a little bit of something that I think is good to know. When these first came out, they were marketed as drugs that would stop beta cell dysfunction. People would be able to take, this maybe with some metformin for the rest of their life and be controlled. And so a lot of people really bought into them and used them, maybe using it as first-line treatment. Hey, I'm going to use this medicine. It'll be the first drug I prescribe because, it'll preserve beta cell function. And then, once you get more and more evidence that it's, maybe these aren't the wonder drugs. They have their role, but not necessarily better. So I think it's always good to think about that when a new drug comes out. Don't be the first to prescribe it. Don't necessarily be the last either, but there's things to keep in mind with those things. This was a randomized controlled trial that compared the lipid effects of pioglitazone versus rosiglitazone, and you can see up there from what happened. The triglycerides went down quite a bit in people treated with Actos. HDL went up more with Actos. LDL went up less with Actos. And so it is interesting that the more adverse cardiovascular effects do seem to be associated with rosiglitazone. So whether that's the reason, I don't know, but I thought that was interesting, and it was a randomized controlled trial. So this is a consensus statement about those, and I'm sorry we have to spend 4 slides talking about one drug, but with all the baggage that they have, I think it is important to be well versed about this. Now your question was about heart failure. Basically, people who have New York Heart Association class 3 or 4 heart failure, don't use them. If you have somebody who's well compensated, and they're on it, you don't have to stop it. I may not add it to that person, but if they're a class 1 or 2 heart failure person, then it wouldn't be wrong necessarily to use it. The other thing to realize is that if you're using them without insulin, the incidence of congestive heart failure is very, very low. Okay, it's less than 1%. People who do seem to get the problems are usually on insulin, okay, or a sulfonylurea. So if you have somebody who's on either of those, then proceed with a little more caution as well. But the big thing is the class 3 or 4 heart failure. If you have somebody who that's weighing every day and calling you with their weights, and you're like, oh no, we better add the Zeroxylin to your furosemide for a week or 2 and get some weight off. That kind of individual, I wouldn't use it. I think also it's important, in the 2009 consensus algorithm from the American Diabetes Association, they didn't recommend, when you look at which medications to start with and then to add, they did not even mention rosiglitazone. So take that for whatever it's worth.